Okay, well, good afternoon, everyone, and welcome to today's pediatric teaching. We've got quite a number of people online, so we'll make a start now. Today, I wanted to talk about um, critically ill patients, I suppose, and it's the overall task of being able to identify and manage deteriorating patients. This is something that is really important for all people in pediatrics, whether it's pediatricians or trainees, pediatric nurses. We all need to be able to identify and manage deteriorating patients because it's an everyday occurrence in hospitals that patients come into hospital with one problem and they deteriorate either because their treatment is insufficient or they need some more treatment or because they had a complication that you didn't quite appreciate or they develop another complication and deteriorate. It's a very, very common problem. It's sometimes the natural history of an illness is to deteriorate, and as good clinicians, we need to be able to identify and manage the deteriorating patient and prevent deterioration. And a lot of hospital quality systems throughout the world have been really based on the prevention of deterioration in children in hospitals, and it's made a big difference to quality and safety in hospitals throughout the world. And it's true that children in hospitals who die or subsequently require intensive care often show signs of physiological or clinical deterioration many hours before their arrest or their collapse. And so the warning signs are almost always there. And it's really up to us to be able to identify those warning signs and then act upon them so that they don't get worse. It's certainly possible if you identify warning signs early to prevent deterioration in children, and hospitals that have introduced programs to prevent deterioration in children have gone from regularly having cardiac and respiratory arrests in children on the ward to having almost none because they can identify and prevent that deterioration. For example, children, there are numerous, I would say even daily examples of children deteriorating in hospitals. And a child who's got meningitis whose conscious state suddenly worsens, and that might be because they have a seizure or they have apnea or airway obstruction. Lots of reasons why their child's conscious state might get worse. A child with pneumonia who becomes more hypoxic, we've all seen that, haven't we? A child who comes into hospital and then the following day they're more hypoxic than what they were when they came in. And often these deteriorations happen despite our treatment. Even though you put them on the right treatment or the standard treatment, they may still deteriorate. And it's just really important that we provide good supportive care so that children don't deteriorate or we identify those warning signs early. A child with dysentery who goes into shock from dehydration or gastroenteritis goes into shock from dehydration because even though you might have calculated the right amount of fluid to give, the child's got ongoing diarrhea. A child with malaria who goes into heart failure from anemia, they might have their malaria treated, but they might have severe anemia, and that might be progressive hemolysis, and then they go into heart failure. A child with severe malnutrition who goes into shock from sepsis, it's very common, isn't it? With children with kwashiorkor or marasmus, when they present, they've often got an infection, a gastrointestinal infection, and that might become more generalized, and then they might go into shock from that. Or the child with osteomyelitis who develops multifocal staph disease in the lung and they deteriorate because of that. Or a newborn baby with birth asphyxia who develops pulmonary hypertension, PPHN, and apnea. We've all seen that. A baby who might have mild to moderate birth asphyxia and the APGARs might not be too bad, but then 24 hours or 12 hours later, they deteriorate with PPHN. These are all the deteriorating patients. A newborn baby with low birth weight who develops heart failure from a patent ductus arteriosus and anemia. Again, we've all seen that. Within baby may be stable at the time of birth and then they deteriorate 3 or 4 or 5 days later. And one of the causes of that might be a PDA, another one might be progressive anemia, another one might be intracerebral hemorrhage, another one might be severe sepsis. So the deteriorating patient won't always have one single cause, but there might be a number of different causes that you have to consider But as I say, this is an everyday occurrence in hospitals, and so it's a core skill for pediatricians to be able to identify, prevent, and manage the deteriorating patient. It could be any disease or combination of diseases like an acute illness, or children with chronic disease who have an acute complication, or it might be their comorbidity, such as I've talked about this, anemia or heart failure or sepsis or pulmonary hypertension. Often deterioration is a precursor for poor outcomes. So when children who have a serious deterioration, if they have a respiratory or cardiac arrest, then often their chance of survival is much, much less. So we really need to look for those signs of deterioration that present often well before their collapse, and they're usually a combination of vital signs and clinical assessment. And as I said, pediatricians and nurses, pediatric doctors and nurses need to be experts in this, in detecting deterioration. And we need to be so much experts in it that we can teach other people about how to do it, including medical students and other nursing staff, how to prevent deterioration. And we need to have systems in place that do that. It's not just one individual skill, it's a whole system that needs to be within a hospital to be able to detect and prevent deterioration. And I'll talk about the systems, which I think they have revolutionized hospitals around the world to have such systems for preventing deterioration. If we go back to the basics about pediatric care and know that all seriously ill children, there are a number of stages that are in the management of any very sick child, including triage, emergency treatment, taking a history and doing an examination, doing laboratory investigations if needed, coming up with a diagnosis and then other diagnoses, giving treatment, providing supportive care and monitoring, and discharge planning and follow-up. And the detection of the deteriorating child can occur at many, many levels. And I've just highlighted the main ones in green, where there's opportunities to detect a deteriorating child. Now that the child might present and they're deteriorating at the time they present. And so at triage, we can detect the child with emergency signs who is deteriorating. Or there will be, in many children, there'll be clues in the history and the examination that the child's actually on a trajectory, a pathway of deterioration, and we need to detect that. In when we're providing supportive care, that's really the mainstay of management of the deteriorating child is good supportive care, be it intensive care or providing oxygen or providing intravenous fluids or many things. And then with monitoring, it's fundamentally important that we have a system of monitoring that detects deterioration. Okay, these are all the emergency signs. I think they're well known to you now, those who've gone through the hospital care for children training, but obstructed breathing, severe respiratory distress, central cyanosis, signs of shock, which are cold hands, poor volume pulses, fast and weak pulse, and slow capillary return. They're signs of shock. And if a child has all of those features, cold limbs and poor pulses, then they have fulfill the definition of shock. They may be in coma, or they may have convulsions or severe dehydration. And any child you see with any emergency signs is potentially a deteriorating child, and one should. That's why they're triage category 1, and that's why they need extra attention and they need extra supportive care at the start. So we said at triage how you assess for those emergency signs. You take a brief history of the presenting problem, you take the child's temperature, you weigh the child so you can calculate drug doses and you can see whether the child's got a very high fever. In terms of the airway, you listen for stridor or obstructed breathing. In terms of breathing, you look for cyanosis and signs of respiratory distress. Check the oxygen saturations if you can. Feel the skin temperature of the hands and feet, feel the pulse and for volume, the capillary refill time, and then assess for lethargy or their conscious level, however you do it, whether it's with the AVPU score or whether it's the Glasgow Coma Score, assess their level of, or whether it's just looking at the child and making an assessment, but you still need to stimulate the child to really assess their conscious level. So assess their conscious state, and this will enable you to detect at triage and on your ward round any of those emergency signs. So it should really, as I've said before, it should take you about a minute or two, no more than that, really, when once you get practice to identify these emergency signs and be able to respond to them. I wanted to talk about a case of a child who I think it's quite instructive, and I'm going to give two scenarios. One scenario where the child wasn't managed very well and the child deteriorated, and then the alternative scenario, which actually happened. So this is a young girl. She was 7 months old and she had respiratory distress. This is a true story. She'd been unwell for about 7 days with cough and high fever, and she'd been unable to feed in the last few days. And she presented to the hospital with cyanosis and saturations of 82%. And when she was given oxygen, it came up to 92. So you'd already conclude from that she's severely hypoxic, and giving her oxygen doesn't even get her saturations up to the normal level. It gets it to close to the normal level, but not to the normal level. When she presented to hospital, she was started on benzoyl penicillin because it was thought that she had moderate to severe pneumonia. So she was started on benzoyl penicillin and she was admitted to the ward. She was given oxygen, but her parents were very worried about her having high fever, very worried. And they asked the nursing staff and the resident on many occasions about the high temperature. It was 39 degrees and above for almost all the time she was in the ward. This was, she wasn't monitored, but if she had been, this was um, her vital signs. And what you can see from this is a monitoring and response chart, and I think all children should have a pediatric color-coded monitoring and response chart. It really helps identify children that are deteriorating and where they're, I'll just go through it. We talked about this before, but it includes the temperature, the respiratory rate, the oxygen saturation, the degree of respiratory distress, mild, moderate, or severe, or normal, the heart rate, the capillary refill time, the blood pressure, the AVPU score, and then any treatment that you might give along the way. Now, if this child had been monitored in this first scenario, this is what would have happened, because when she came to hospital, when she was admitted to the ward, her respiratory rate was just in the amber zone, just in the slightly concerning zone, but not in the danger zone. But over the next hour, a couple of hours, her respiratory rate went up into the red zone. And at that stage, there should have been a response. And I think this is the key thing. When a child goes into the red zone, there should be a response that you change something, you have another assessment, you make sure that there's no complications. And this child went up into the red zone in several areas. If a child goes up into the red zone in one, that's certainly worrying. But if they go up into the red zone in several variables, several vital signs, then that's extremely worrying. And this child, when Joy went up in the red zone, into the red zone with her respiratory rate, so it was very high. Her temperature, as I said, was always high, like 39 or above most of the time. her her oxygen saturation, which had been okay when she came in on oxygen, 92% acceptable, even fell on oxygen to the mid 80s. And her oxygen, the amount of oxygen that she received actually increased. This tells you the amount of oxygen the child's receiving in litres per minute, and you can see it going up. Her respiratory distress went from moderate when she came in to severe several hours later, and it stayed that way most of the night. Her heart rate increased into the red zone as well, from the white zone, the safe zone, to the amber zone, when there should have been some reassessment, because it was concerning, and then into the red zone. And then you'll notice it actually went down. I'll talk about that in a minute. Her capillary refill most of the time was okay, and then in the last hour before she arrested, her capillary refill was prolonged. she remained alert most of the time, except when she arrested. So you can be, you can sometimes people look at one variable and they say, well, this vital sign is okay, so the child's okay. But you have to look at the overall picture and look at it, look at all the variables. So if there's one or more that are deteriorating or getting worse, then that's concerning. Don't be falsely reassured by one vital sign that still remains okay. I've seen many children who the health workers say, "Oh, but the heart rate was okay. The heart rate stayed in the normal range, or despite the other deteriorations, the child remained alert." Well, that's not good enough because some children they deteriorate in certain ways in a very severe way, but one of their other vital signs might remain okay. So don't be falsely reassured by that. Now she was admitted to the ward at 1600 hours, so 4 o'clock at night. Always a danger time in a way because the staff are just going, the doctors are just going home at 4:30, 5 o'clock, and the question is who's going to monitor her overnight. She was given antibiotics on admission appropriately, the benzoyl penicillin, but she remained febrile and tachycardic and tachypneic, and all of those things went up. She had increasing oxygen requirement throughout the night. And by the following morning, after not being assessed overnight, she then was gasping and then had a respiratory arrest. And she was intubated and had CPR and could not be resuscitated. That sadly is a very common scenario. And you can see that the time in which this could have been identified, this girl Joy could have been identified as being more sick was very early on. In the first couple of hours of her admission, it didn't have to wait all night. Well, that's what could have happened when she had an X-ray. This is what the X-ray showed. But I want to show you what actually did happen. This is a better scenario. This was Joy being monitored, and this is a better scenario. So she was admitted at 1600 hours at 4 p.m. She was given the antibiotics, the benzoyl penicillin admission, but she remained febrile and tachycardic and tachypneic, just as I mentioned. She had increasing oxygen requirement in the afternoon, and then in the evening at 10 o'clock, 10 p.m., her respiratory rate was in the red zone, and so the the resident and the registrar got very concerned, and they called what's called a MET, a medical emergency team. And then based on that, the senior registrar and the nurse who was in charge of the shift came, attended, and even an anaesthetist came. Anaesthetic registrar came down and they ordered a number of things. Firstly, to increase the oxygen. Secondly, to move the child to the ICU, to the pediatric intensive care part of the ward where the child could have better monitoring. They got an urgent chest X-ray, and I've just shown you that. Clearly on that X-ray, there was some concerning features, and that was that there was a whiteout of the left side of the chest. And so that was identified early, not when she deteriorated and had an arrest, but it was identified when she had the earliest phase of deterioration, when her respiratory rate went up into the red zone and her oxygen saturation started to drop despite increased oxygen. So clearly the reason for this child's deterioration, she did have pneumonia, the diagnosis was right, but it wasn't the only thing that she had. She also had an empyema, and that was seen on the X-ray. That was drained by an intercostal catheter overnight, and put that child on the ward, and 300 mils of thick pus. She on the ward. This was the chest drain was inserted with some ketamine as an anesthetic because she was deteriorating rapidly, and there was no possibility of getting operating theatre opened up at night. So the senior registrar was able to do that on the ward using some ketamine to sedate her with lightly. And then her antibiotics, because of the pus, were changed to ceftriaxone and flucloxacillin. After draining all that pus out, then her respiratory rate came down, her oxygen saturation went up, her heart rate came down. She remained alert, and things were much better in the morning. She was put on some furosemide to reduce edema because she'd already accumulated edema. This was her chest X-ray in the early hours of the morning after her The 300 mils of pus was drained out. You can see she's got some pneumatoceles there, so you'd be thinking maybe she's got staph pneumonia. So you've already, this child's been had an intervention done in a timely way after a few hours of being in the hospital, rather than wait until the early hours of the next morning and she's deteriorated to the point of having a respiratory arrest. The outcome was good. She stabilized, her fever decreased because the pus was drained out, her respiratory rate decreased, her heart rate normalized. She needed less oxygen by the next morning. Staph aureus, not surprisingly, was grown on pleural fluid. Intercostal catheter stopped draining after 3 days, and that was removed. And she had 10 days of IV flucloxacillin, and that was changed to oral fluclox for the rest of the 10-day period. By a few days, she was taking breastfeeds well, and she was discharged well after 3 weeks. She remained on antibiotics for 20 days because there was a lot of pus and Staph aureus was grown. So for nearly 3 weeks, she was on antibiotics, and then she was well and discharged. And she was followed up in the clinic a couple of weeks later, and she was well at that stage. Her nutrition had returned to normal, and her respiratory status looked much better. And she was given some vaccines. So a good outcome for this child only because her deterioration was detected early and not at the time that she had an arrest. Usually in the handovers in the morning, we often hear about children who are arrested. What's more important is what they look like 6 or 8, 12 hours before. So many hospitals around the world have introduced something like a MET system. It doesn't have to be a big team of people. It might only be an alert that's made by a resident or a registrar or by a nurse, and they call someone else who has more skills, I would say, in the assessment and management of critical illness. And it doesn't have to be a big team. Many hospitals function with just a small team of a doctor and a nurse, a senior registrar, someone who's skilled in done some APLS training or may have some training in intensive care, a pediatric doctor who knows the patient, and usually the nurse in charge of the shift. It's important that they attend. And you can base the criteria for calling a MET on a number of things. You could base it on the WHO emergency signs. When those things are identified, then a MET is called. I would think best to base it on a combination of things. If you see the emergency signs, if a child goes into the red zone on the color-coded pediatric monitoring charts, or even if the parents are very concerned, it's well worth calling a MET. Many hospitals have what they call parent-initiated METs, which means that if a parent is very worried about their child, they can ask the residents or the nurses to call a doctor to review the patient. And that call can go out on a mobile phone, it can go out on a pager or an overhead speaker or something to call a MET on this particular patient in this bed, in this ward, and a skilled team of people. It might be only 2 people or more can come and assess the child. It's often really important to have people who either know the child or maybe even people who've never not seen the child before, and they make a fresh assessment of the severity of the child. These MET systems have been introduced in hospitals all throughout the world, and they have made a revolutionary difference to the safety of pediatric wards where the nurse patient ratios are not very high. For example, even where the nurse patient ratios are not high, a MET system can be a good safeguard. There's lots of different names for the MET type systems. There's one called PEWS, which is the Pediatric Early Warning Signs. There's one called PTTS, the Pediatric Track and Trigger. They're all saying the same thing. You monitor the vital signs, you record them, you track whether or not a child's going into the danger zone or not, and you have some response. Rapid response systems, they're the same. They're more or less the same. And they're based on the recognition of deteriorating in physiological parameters, deterioration in physiological parameters. And there've been a large number of studies now on early warning systems, MET systems, whatever, and including 55 different studies. They've all been reviewed, and many studies show a reduction in hospital deaths, and some type of MET system has been adopted in hospitals worldwide, in countries all throughout the world, whether high or middle or low income countries. MET systems have been invaluable. The principles of a Met system, it's really important to understand the principles. Remember, I said it's not just the skill of one person, it's the principles of the Met system and the system itself that's important. Firstly, you need to have symptoms and signs of deterioration that are recognizable and recognized by health care staff. Um, you can't have, as part of a Met system, um, signs or laboratory tests that aren't possible to do. You just have to have basic clinical signs that healthcare workers can be taught to recognise. Secondly, the second principle is that the staff on the ward need to be empowered to call for assistance without having to. Usually, there's a hierarchy where the nurse has to call the nurse in charge, and the nurse in charge calls the resident calls the registrar, and the registrar calls the senior medical officer or the consultant. And before, for example, someone from intensive care is called or an anaesthetist is called. No, you need to be able to circumvent these hierarchies because it's only when those sort of hierarchies exist, then it takes a very long time for the child to get the right people at the bedside assessing them. So the ward staff need to be empowered to call a MET and call for assistance certainly without being criticised, even if the child's not too bad, then really important not to criticise them or to disparage them, but to get the right people at the bedside who can make an assessment. A readily available urgent response needs to occur. And this response, along with whatever interventions, whatever changes you make, then will improve outcomes. So they're the principles of a MET system, and that's why it's worked so well. A key feature, as I said, is the empowerment of all staff, including junior doctors or nurses or even parents of children, to summon help without deferring to senior colleagues or necessarily to other medical staff, to circumvent those hierarchies and just make sure that the patient gets the right people. There's some if you read the literature, you'll realize that there's lots of different systems, like scoring systems. I think the color-coded monitoring charts are the most simple and probably the most effective. Many studies have shown that using these color-coded monitoring charts, you can get a reduction in hospital deaths. This is a study from the Royal Children's Hospital in Melbourne, where we used to see about one cardiac or respiratory arrest a week at the Royal Children's Hospital. And then after the Met system, it became a very, very rare event for a child to have a cardiac arrest on the ward. This is this is the color-coded monitoring response chart. I had mentioned it before, and it's really important, I think, to use something like this for all children, certainly in your high dependency area, but even in the rest of the world. If you can use a chart like this, then and you need to teach healthcare workers how to use it properly, how to not only how to plot the chart, but also how to interpret the changes that they might see. This is fundamental to communication and fundamental to appropriate monitoring. The effectiveness of any system does depend on a number of things. Well, firstly, you need to listen to parents' concerns about their child's condition, both at the triage and while you're monitoring the child on ward rounds. Really listen carefully to the parents' concerns. This is especially the case. We've found in over 20 years now of having a Met system, I've found that the parents of children who are chronically unwell always know their child best, whereas doctors, other healthcare workers, they don't know just what the baseline state of the child is. And so parents can always identify when their child's worse than what they normally are. And this is really important because some doctors might not be able to identify this. So listen to parents, inform parents about the expected course for their child based on the diagnosis you've made. And then it's useful to tell parents to what other signs or symptoms to look for, which should prompt reassessment. I think we have to engage parents in this exercise as well. We need to teach staff how to use pediatric monitoring and response charts, and we need to teach staff skills for monitoring and attending emergency calls like MET calls. Before before there was a MET system in most hospitals, what they had was a code blue system. And the code blue system means that the child actually has to have a cardiac arrest before before help is summoned. And this is what used to happen. Certainly in my hospital, 20 years ago, a child um, would have a cardiac arrest, and then they'd call a code blue, and people would run to the child and, of course, give resuscitation. Well, that has that that resulted in the outcome that you might expect in the vast majority of cases. But when you have a MET system and you get early warning, early responses, then you can prevent these cardiac arrests. So staff need skills in monitoring and attending MET calls. It's a skill to practice, to teach. Firstly, the recognition, which we've talked a lot about. Secondly, the analytical process that has to happen at the bedside. You need to ask the question, what's going on? Why is the child deteriorating? If people hadn't asked the question about that case I mentioned about Joy, then they might not have got a chest x-ray. They might not have identified that she had an empyema and then done something about it. And so there's a need for clinical analytical skills that we need to teach registrars and residents. It has to be practical. If a child is deteriorating, you need to do something about it. It's not good enough to just say, well, they're deteriorating and there's nothing we can do. You have to change something. Even if what you change, you might change two or three things, and two of them don't work, but the third one does. The point is to change something so that the child's situation can potentially improve. And the change has got to be based on your analysis of what the problem is and what is lacking in the child's treatment, or what more you can do. And then communication skills, so recognition skills, analytical skills, practical skills, and communication skills. You have to inform staff so that everyone follows the plan, and that you hand over the child properly. Now, I often see at handovers children being handed over without a real assessment of the severity of illness of the child. And so when you're handing over a child in the morning, it's not enough to just hand over that the child's been admitted, but you need to make um, for those who are critically ill or seriously ill, you need to be able to convey that. And we need to be able to teach those skills to our registrars and our residents to be able to communicate severity of illness so that it's, in a way, it's like a continuous triage process. You're continuously triaging patients to, in your mind and in the way you communicate. Is this child stable and safe? Are they concerning? Are they critically ill? It's the same as triage categories 1, 2, and 3, or severely ill, moderately ill, mildly ill. You need to be thinking along those lines and to be able to communicate in words what the situation for that child is. When you're analysing the situation at a med call or on a ward round, then there's a there's a system of communication called ISBAR, identification, situation, um, and so you need to ask yourself, well, what's the situation? What is the situation for this child? What's the background? What's the diagnosis? Is the treatment that's currently being given sufficient? Are there unrecognized diagnoses or problems that need treatment? These are all the questions that you can ask at a MET call, when you get called to see a seriously ill child or a deteriorating child. What's the nature and causes of the deterioration? And what factors can we change? What things can we change to make this somewhat better? Or, how do we do that? How do we change something that will make the child better? And who else is needed to assist? It's not always the person who gets called to the bedside who has to do everything, but they may then call someone else who is required, whether it's a surgeon or an anaesthetist or it's a consultant pediatrician. If a child has a med call, then the SMO should be notified, or a very senior registrar or pediatric fellow should be notified, so that you're sure that there's been a escalation of communication. Sometimes when we're assessing a deteriorating child or a child at the bedside, it's useful to have a sort of alphabetical algorithm. And this is what I usually go through. And it doesn't have to be done in this order, but I always find it quite useful to think about this in a seriously ill child. So think about the airway. Is a stridor, upper airway obstruction? We talked about this before. The breathing, go through the same things. Look at the circulation, and then disability or the conscious state. What's their neurological state like, their GCS response to pain, the level of analgesia, is it adequate or not adequate? Review all their drugs, check the doses, what drugs are no longer needed, you might cross some off. Exposure, think about the child's environmental temperature, their other things. That have they got an IV cannula, or do they have pressure areas that need attention? E for electrolytes, creatinine, urea if needed. F for fluid balance. Is there a edema, dehydration? Think about feeding. F for feeding. G for glucose. Is the blood sugar normal? H for hematology. Are the signs of anemia or signs of infection on the full blood count? I for clinical signs of infection. You don't need to go through the whole alphabet, but it's useful to have a systematic approach to a child in a ward round. When you're at a met call, it's usually just, can you identify signs of deterioration, and then analysis of what you need to do about it. So I hope that's been a bit useful to you. I think many hospitals would benefit from having a simple MET system, and um, and I hope that these sort of things can be introduced in the coming year or so. The last thing, my last slide, is that it's always important to have, well, it can be important to have a second opinion by an experienced pediatrician, and you shouldn't. I mean, I think when sometimes we think that there's just the team, the resident registrar consultant, or the registrar and the consultant, and they have to manage the patient. But it's there's always value in having a second opinion by a pediatric clinician, senior pediatric clinician, when questions remain about the diagnosis, when you're not quite sure, when signs are atypical. The child might have this, or not sure, maybe they've got something else. When normal resolution is not occurring with adequate treatment. This is common, isn't it? That we start standard treatment, but for some reason the child's not getting better. And sometimes at the request of parents or caregivers or other staff caring for the child, the nurses might say, "Oh, I don't think something's not right here, and maybe we can get someone else to look at the patient." You should always be open to the idea of getting a second opinion. Um, I do that often in critically ill patients. So don't be scared of seeking a second opinion that might help you understand better why the child's deteriorating. All right. Well, that's all I really wanted to say today. But I hope that's been useful, a bit useful in explaining about the deteriorating patient, about how we can prevent and detect and manage the deteriorating child. All right. I'm going to stop recording now, and I'm happy to answer